courses and other PG students and now surgeons, all are participating in this meeting.
Okay.
First of all, I am very much thankful to Dr. Manju Pillai for accepting our invitation to.
It's my pleasure.
Teaching us the advances in medicine. That's one of the things. So most of them know now they will know much. I introduced personally to many of the people about the Dr. Manju Pillai regarding the humble and other academic caliber. I came to know that in academics. Same time as I think you are graduate from Alappuzha Medical College.
Yes, Alapi. Yeah.
All the basic things I introduced to our department. I think we are waiting for the people to join.
Sure. Yeah, I can wait. Yeah.
We'll wait for 5 minutes.
Yes. Can I start sharing my slides?
Start, definitely. Yeah.
It's not letting me share.
Ma'am, you will be able to share it now. Can you please check?
Who can start sharing when someone else is sharing? Only host or all participants?
This, as you all know that this Dr. Manju Pillai is Associate Program Director, Division of Pulmonary and Critical Medicine and Sleep Medicine, New York University, Yonghae Health. And she is a very bright and meticulous teacher. And that's what information I got it actually. So this is a grateful from the Department of Medicine. I should thank you for coming and sharing your knowledge with what is happening the other side of the world, because we are also coping with that, but we are lagging in certain areas definitely. And today's is biologicals in bronchial asthma. We are waiting for you to deliver your talk. Thank you, Dr. Manju Pillai, welcoming you. Thank you.
Okay. Thanks for the invitation, and it's my pleasure to give the presentation today. Can I start, or you want me to wait?
Yeah, start. We'll start because
start the presentation.
Yeah.
Okay.
Only our students and students will come slowly one by one. That's a usual trend.
So, as I was introduced by Dr. Mohan Varghese, my name is Manju. I graduated in 2002 from Alleppey Medical College, and then I moved to United States, and I did my residency in Cleveland, my pulmonary critical care and sleep medicine fellowship in Denver and Mount Sinai, New York. I worked in Memorial Sloan Kettering Cancer Center initially, and then moved to New York University, Long Island Medical School. It's a pleasure for me to do the presentation today. I'm not sure if biologics are used in Kerala and which ones are used. But we'll go through the biologics in asthma and the commonly one used in United States here. I do not have any disclosures. So the learning objective will be to define asthma and briefly go through the pathophysiology, explain the GINA guidelines for the management of severe asthma, because we use biologicals mainly in severe asthma, and the role of biomarkers, especially FeNA, sputum eosinophils, IgE, and how to decide on which biologicals to use in the management of severe asthma. If we have time, we'll go through the use of biologics in pregnancy as well. We don't have much data about that so far. So asthma is a chronic disorder of the airway characterized by variable and recurring symptoms due to reversible airflow, obstruction, bronchial hyperresponsiveness, and an underlying inflammation. If this is the normal airway, in asthmatics, the airway becomes inflamed and thickened. And in exacerbation, the airway becomes more tight with inflammation, secretion, smooth muscle thickening, and it can also lead to air trapping because the airway is so thickened, all the air cannot be exhaled out, leading to air trapping. I do not have the epidemiology of asthma in India, but in United States, it's usually seen in African-American population. They have more poorly controlled asthma, and it's more severe in women. Over the last 15 years, the asthma-related mortality has declined here in the United States. When we talk about the pathophysiology of asthma, when we are exposed to an allergen, the Th2 pathway, asthma is a Th2 pathway mediated disease, and it's activated to produce IgE antibodies. And allergen-specific IgE antibodies are secreted by plasma cells. The IgE will bind to high-affinity receptors on mast cells and basophils, and there is cross-linking of IgE antibodies allergen on mast cell surface, leading to degranulation and mediator release, leading to asthma symptoms. So the asthmatic response can be divided into two phases. The early phase, which is an immediate response, usually to an antigenic or to an environmental stimuli that initiates the local mast cell activation and mediator release, leading to acute asthmatic attack. This initial phase will often resolve in few hours. And this is followed by a late phase. The late phase is induced by inflammatory cell infiltration, and it can last for a prolonged period of time. So the constant exposure of the allergen continues to promote inflammation and causes long-term damage to the airway, leading to severe consequences in chronic asthmatics. So this is another graph looking into the pathophysiology. When exposed to allergens, the dendritic cells and other inflammatory cells, such as the mast cells, they activate the Th2 lymphocytes. So as I mentioned before, asthma is a Th2 lymphocyte mediated disease, and Th2 lymphocyte will produce interleukin 4, 5, and 13, which activate the eosinophils. Mast cells produce interleukin-13, which can activate the eosinophils as well. So this is the basic pathophysiology we need to learn to know about the biologics in asthma. So the Th2 lymphocyte, the three interleukins it produces, interleukin 4, 5, and 13. Now we have a new one, that is the TSLP, that is the thymic stromal lymphopoietin, which is an epithelial-derived cytokine that can activate Th2 lymphocyte as well. So now we have biologic agent targeting TSLP, which is the latest one. So when it's a very, when I was a medical student and I see a table or graph like this, I get confused, okay? So it's over here to talk about the biologics, we just have to know about the Th2 lymphocyte, because asthma is a Th2 lymphocytic disease, pathway disease, and it activates, it causes interleukin 4, 5, and 13 production that activate the eosinophils, okay? So when we go through the presentation, we'll be talking about this pathway again, and we'll introduce more interleukins, and we'll get more confused, throughout the talk. So when we talk about asthma, we discuss about 4 different types of cells: the eosinophils, mast cells, basophils, and the Th2 lymphocytes. And these are the 3 interleukins that we'll pay attention today, the 4, 5, and 13. So eosinophils are recruited and activated by interleukin 5. And eosinophils are related to disease severity, and they release leukotrienes, a platelet activating factor that can cause smooth muscle contraction. So if there is an interleukin 5 monoclonal antibody, it can decrease eosinophil, right? So interleukin 5 is an important interleukin that we need to know about. Mast cells, they produce different kinds of mediators, and they cause bronchoconstriction and growth of airway smooth muscles. The basophils, they produce histamines and leukotrienes. They produce interleukin 4 and 13. The 4 helps the Th2 cells and B cells to produce IgE, okay? Now the Th2 lymphocyte produces these 3 interleukins. The interleukin 4 that helps differentiating Th2 cells and switching lymphocyte immunoglobulin synthesis to IgE. Interleukin 5 regulates eosinophil production and survival. And if there is interleukin 13 causes airway eosinophilia, mucus gland hyperplasia, airway fibrosis, and remodeling. So interleukin 4, it stimulates the B cells via the Th2 cells produce interleukin 4 that increases the synthesis of IgE. Interleukin 5 is increases eosinophil production. If there is airway eosinophilia, then there is increased interleukin 13 production. So to know about the biological agents in asthma, these are the 3 interleukins that we need to know about. The newer one is the thymic stromal lymphopoietin. That's an epithelial-derived cytokine, and it is central to the regulation of type 2 immunity. And there are a lot of studies going on regarding type 2 immunity and asthma. Now, the most difficult variant of asthma to treat is the neutrophil predominant asthma. So the neutrophil contributes to airway gland hypersecretion, bronchial hyperreactivity, and airway remodeling. These are patients who are on increased use of oral corticosteroids. It's very difficult to wean these patients off the steroid. And this variant of asthma is associated with incompletely reversible airway obstruction. So even though I said we'll pay attention to 3 interleukins, 4, 5, and 13, interleukin 17 is the one that is newly introduced. That causes neutrophil infiltration and neutrophil predominant asthma. Now, since we know how to treat severe asthma with the biological agents, pharmaceutical companies are looking into more interleukin pathways, different phenotypes and endotypes of asthma so that we can develop biologics to treat more difficult variants of asthma. So that will bring us to the GINA guidelines, that is the global initiative for asthma guidelines. So when we treat an asthmatic patient, we do step up and step down treatment. So when we see a patient with asthma in our clinic, we start, if they have mild symptoms, we start with inhaled corticosteroid. If their symptoms are not controlled, we add a long-acting beta agonist, that is like formoterol. If it is still not controlled, we add a LAMA agent, that is an anticholinergic agent. So if asthma is still not controlled, we go and look for biomarkers and see if they qualify for biological agents. So to get these agents approved by insurance, because they are very expensive medications, we have to prove that we have tried all the medications that's commonly used. We look at the biomarkers. The patient has moderate to severe asthma with frequent exacerbation, hospitalization. So when we prove all these things, then they qualify for biological agents. It's much easier to get these agents now when compared to 10 years ago. So we are moving more towards biological agents here because patients' asthma symptoms are better controlled. If they use inhalers, it depends on how good the inhaler technique is. If the inhaler technique is not good, that's the most common reason why the asthma is not well controlled. When it comes to these agents, these are shots or injections, so they respond more to these agents when compared to the other treatment options that we have. So now we look into asthma, we look into the asthma syndrome. The asthma syndrome is characterized by recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and inflammation. And there are different phenotypes and there are different endotypes. Phenotype is the clinical presentation, trigger, and the treatment response. And endotype is the pathway that led to the phenotype. So it's very difficult to understand what a phenotype is and what an endotype is. So endotype is the different pathways that lead to the phenotype. So we'll go through, different types now. So there are T2 type asthma and the non-T2 type asthma. As I mentioned, asthma is a T2 type inflammatory pathway activation. So T2 causes childhood asthma symptoms like allergic asthma, exercise-induced asthma, eosinophilic asthma, aspirin-exacerbated respiratory disease. When it comes to non-T2 type asthma, we're talking about obesity-related, smoking-related, smooth muscle-related paucigranulocytic asthma. So instead of one term asthma, when I was a medical student, it was only one term asthma. Now we have different phenotypes, we have different endotypes, and it's very important to know this so that we can treat them appropriately. So again, coming to this graph again, so we have different endotypes or phenotypes of asthma. So we have allergic asthma, we have an eosinophilic asthma, neutrophilic asthma, and paucigranulocytic asthma. So if you look at this pathway here, when there's an allergen, it activates the dendritic cells. The dendritic cells will form the Th2 lymphocyte activation. The Th2 lymphocyte causes interleukin 4 and 13 that activate the B cells to produce IgE. It can also activate the mast cells to produce IgE. It can also activate the basophils that can activate the B cells. So in the allergic pathway, more IgE is produced through the Th2 pathway. When it comes to the eosinophilic variant, the Th2, with increased interleukin 5 production, the eosinophils are activated. There are more eosinophilic variants here causing the eosinophilic asthma. And the neutrophilic one, when allergens, epithelial cells are exposed to allergen, the dendritic cell causes Th17 activation that causes more production of interleukin 17 that causes neutrophilic activation and infiltration. That's neutrophilic asthma. The TSLP, that's the newer one that we have discovered, it can activate any of these pathways. It can activate the allergic, the eosinophilic, the neutrophilic, or the paucigranulocytic, where it activates the fibroblast. So when you look at the paucigranulocytic variant of asthma, there is no neutrophil or eosinophil or inflammation of the airway, but there is proliferation of the fibroblast leading to airway remodeling, okay? So all these, they have inflammation in the airway. This is mainly allergic, that is IgE mediated. Here there is eosinophils, here there is neutrophils, and here there is no inflammation, but there is remodeling of the airway. So that's the, the new different, not new, but over the last several years, we talk about these different variants of asthma. So again, we came to the same table about different kinds of cells and the Th2 lymphocyte, because asthma is a Th2 lymphocyte activated pathway. And it produces the three interleukins that we have biologics now is the interleukin 4, interleukin 5, and interleukin 13. So when over here, primary care physicians take care of asthma if they're mild. So they give them inhaled steroid. So if the patients have recurrent exacerbations, they are on steroid frequently, especially during seasonal changes, or they get frequent hospitalization. So if patients have asthma, COPD, or any chronic conditions, heart failure, if you have recurrent hospitalization, it's not good for the doctor, who takes care of them, okay? Insurance doesn't like it. So that's the time they refer patients to the specialist. So when we see patients patients with asthma in our clinic, they usually are coming with moderate to severe asthma. So when we see these patients, we talk about their history, examination, if there are any triggers. In asthma, before we go to biological agents, we ask them if there is any trigger, if there is any mold in their house, if are they allergic to any pollens, grass, weed. They usually have cats in their house, pets inside the house. So if they're allergic to any of those things. So after the history, we usually look for biomarkers. The common biomarkers we look for is the total serum IgE level. We look at the absolute blood eosinophil count, the sputum eosinophil level, BAL, that's the bronchoalveolar lavage. Like in my practice, I usually don't do bronchoscopies in asthmatics to look for eosinophils. It's mainly for research interest, or in some centers they do that. But over here, we don't do bronchoscopies in asthmatics to look at the cell types. But if they have very resistant or refractory kind of asthma, that's something that can be considered. We also look at the fractional exhaled nitric oxide, that is the FeNO. FeNO is a marker of airway inflammation. So when patients do lung function test, that is the pulmonary function test, they usually do a FeNO along with the lung function test here. So these are the 4 biomarkers that we look for, based on which we can decide which biological agent we can use for our patient. So as I mentioned before, it can be an allergic type of asthma, like the T2 endotype asthma or T2 low asthma. The T2 high is the allergic eosinophilic or the asthma with high pheno level, or the T2 low is the neutrophilic or the polygranulocytic asthma. So the T2 low asthma is the more difficult variant to be treated. So those patients are usually obese, they smoke, they have high fat diet, they have poor response to steroid, they're chronically on steroid. Most of the time it's due to neutrophilic airway inflammation and they have fixed airflow obstruction. The polygranulocytic, as I mentioned before, they have low level of inflammation. Like eosinophils and neutrophil level is low, but they have airway smooth muscle dysfunction. So they are less sensitive to steroid when compared to the other variants of asthma. So those patients, we are trying to see if bronchial thermoplasty will be a good option, where we do bronchoscopy and we try to reduce the muscular wall thickening in asthmatic patients. The FeNO is a fractional exhaled nitric oxide. It's a measurement of the airway inflammation. And if FeNO level is high, is associated with a decline in lung function. So it can be elevated in asthmatic patients or in any conditions where airway eosinophil level is high. So if patients have cystic fibrosis or smokers or alcohol consumption, it can be false negative or low. So when patients come for PFT and for FeNO testing, we ask them not to eat hot dog prior to the testing, because hot dog is rich in nitrate and the FeNO level can be elevated falsely. So as I mentioned, FeNO then is a marker of airway inflammation. It is not associated with blood eosinophilia, but is associated with airway inflammation and airway eosinophils. And it can be elevated in eosinophilic bronchitis, allergic rhinitis, etc. So there are different FeNO guidelines, and what we look for is a FeNO more than 50. If FeNO is more than 50, we think those patients will respond to inhaled corticosteroids better because they have more airway inflammation. So when we come to the biologics in asthma, so I'll go through this pathway again, So as I mentioned, asthma is a Th2 lymphocyte-mediated condition, and the Th2 lymphocyte will produce interleukin 4, 5, and 13 that will drive the B cells to produce IgE. The mast cell-bound IgE causes degranulation and produces the prostaglandins, leukotrienes that can cause bronchoconstriction. So IgE, the interleukin 5, interleukin 4 and 13 are the targets recently for the development of biological agents. Now we are trying to develop against interleukin 17 for neutrophil predominant asthma as well. So when we talk about IgE, that is one of the pro-inflammatory cascade in allergic asthma, omalizumab, this is the first Xolair, this is the first FDA-approved biological agent used in the treatment of asthma. And it binds to IgE so that it doesn't cause activation of the mast cell and release of interleukins, leading to less bronchoconstriction and relief of asthma symptoms. The next, we look at interleukin 4 and interleukin 13 that is produced by Th2 cells, that causes B cell activation and production of the IgE. The agent that we have is the dupilumab, that is Dupixent, that is interleukin 4 receptor blocker that can reduce the interleukin 4 and 13 production. Then we have monoclonal antibody against interleukin 5, that is the mepolizumab. That is the commonly used one compared to the reslizumab that can decrease the eosinophil production. We have is the interleukin 5 receptor blocker, that is the benralizumab. So these are the commonly used biological agents, the Xolair or the omalizumab against IgE, the mepolizumab and benralizumab, that is interleukin 5 and interleukin 5 receptor antibody, and the interleukin 4 receptor antibody. The latest one is the TSLP monoclonal antibody, the tezepelumab. Okay, so we'll go through all these things again. I'm not sure if these medications are used there. If these are not commonly used medications, it's difficult to follow, but it's just to say that there are different kinds of agents that are used, and this is the new way of treating asthma. We are going away from inhalers to these injections and shots that the patients can take less frequently. They don't have to be concerned about carrying inhalers with them all the time. So when we talk about the biologics in asthma, we are basically talking about these 5 medications that's FDA approved here. The Xolair or omalizumab is approved in 2003, and it's an anti-IgE antibody. So there are several large clinical trials that have shown clinical benefits of treatment of omalizumab in patients with severe allergic asthma. So if the IgE level is elevated, it's like an allergic type of asthma. So it have shown reduction in asthma exacerbation and also decrease the dose of inhaled corticosteroid and oral corticosteroid. So in patients who used omalizumab, the steroid dosing was reduced by 50% in almost 75% of these patients. So since FDA approved this medication, we have so many clinical trials going on. So the PERSIST trial, the EXPERIENCE trial, that those are the real world studies that happened after the clinical trial and FDA approval. They also showed that it decreases exacerbation, and it's far better than better management of asthma. So now the later one is the INNOVATE trial that examined the relationship between IgE and omalizumab and clinical outcomes. So once the medication is started, the IgE level can go down very fast. So when we start these medications, we follow the IgE level. So as soon as the shot is given, the next visit, the IgE level goes down. But their symptoms, their peak expiratory flow rate, they all come back to normal, or they get better only after 18 to 20 weeks. So when after giving 1 or 2 shots, we don't stop it. We at least try it for 3 to 4 months before we say that this is not working for this patient. Okay. So the most common side effect that we see is nasopharyngitis, headaches. They can have anaphylactic reaction. Xolair or omalizumab is usually given in our clinic. It's not a shot that they can take at home. So that's one of the disadvantages of this medication. They have to come into the clinic to get these injections. So once the medication is stopped, there was some randomized retrospective study. It's not randomized, a multi-center retrospective study in France that showed that once this medication is stopped, the IgE level comes back to normal in like 16 to 20 weeks. And after 6 months, half of the patients did not have asthma exacerbation. So we don't know what happened to them after 6 months, but at least for a short period, their symptoms did not come back. In my practice, once I started, it's very difficult to take them off these medications. So the other commonly used medication is the interleukin-4 receptor blocker, the dupilumab, that downregulates interleukin-4 and 13, that was approved in 2017. It has also been shown to reduce exacerbation, hospitalization. There was decreased use of steroid in these patients as well. When it comes to interleukin-5 antibodies, mepolizumab, we use mepolizumab more than restylizumab. It might be because it's more readily available for us. It was approved in 2015. So as you know, interleukin-5 is eosinophil driven, right? It activates the eosinophils. So if in any eosinophilic disease, the hypereosinophilic syndrome, EGPA, chronic rhinosinusitis, in all those diseases, the mepolizumab can be used. Or you can use benralizumab, which is an interleukin-5 receptor blocker. So all these medications, these are the 5 medications that we use currently. Xolair is the one that's approved first and is mainly used in allergic variants of asthma. If we want to target multiple pathways, we use dupilumab that downregulates interleukin-4 and 13. If there is an eosinophilic variant, then we use mepolizumab or benralizumab. So the advantage of all these medication is that they can take these shots at home. So the first one we give in the clinic, and then they can take it at home rest of the time. So that will bring us to the workup of severe asthma. So when we have a patient with severe uncontrolled asthma, this is the algorithm that we follow. We look into the blood eosinophil level. We send the sputum cytology for eosinophil. Say if it is very refractory kind of asthma, we can do a BAL, but it requires over here anesthesia and the side effects of anesthesia, and it's a procedure. So we try to avoid procedure if possible in asthmatics, because bronchoscopy can trigger the airways and they can go into exacerbation after that. We monitor the lung function test and the FeNO level. And we also look into different kinds of allergens that they are sensitive to. So after this testing is done, we look into, do they have any other comorbid conditions? The asthmatics, if it is allergic, or what kind of variant they have. They can have nasopharyngitis, they can have dermatitis, they can have hypereosinophilic syndrome, eosinophilic pneumonia. So some biological agents can be used in different comorbid conditions as well. So this will help us to select the right biological agent for the asthmatic patient. So then we see if they are oral corticosteroid dependent or not. If they are steroid dependent, it's very difficult to wean these patients off steroid. The moment you wean them off, they get an exacerbation and they end up in the hospital. So in these patients, the commonly used agent is the interleukin-4 receptor blocker, that is the Dupixent that we commonly use, or you can use the interleukin-5 or the 5 receptor blocker, that is the that suppresses the eosinophils. Now, if you are not an oral corticosteroid dependent person, then you can look at the blood eosinophil level and decide which one to use. So when you look at the blood eosinophil level, if it is less than 150, okay, if the blood eosinophil level is low and the FeNO is low, that means the airway eosinophil level is low, but they have an allergic type of asthma, like due to seasonal changes, they get asthmatic attacks, you can consider the anti-IgE agent. Okay, so I'll skip this pathway for now. We'll look into the navigator trial and see whether this is right or wrong, because I thought in this protocol, this is a wrong pathway. Now, if the FeNO level is high, more than 25, and if they are allergic, you can either use IgE or the interleukin 4 or 13 monoclonal antibody. If they have no seasonal allergies or allergen, they can use the anti-interleukin 4 or 13. So if the blood eosinophil level is between 150 to 1,500, so if the blood eosinophil level is high when compared to FeNO, so the blood eosinophil and FeNO are two different things. FeNO is a measurement of airway inflammation, and it does not correlate with the blood eosinophil level. So if the blood eosinophil level is high, you can target medications that can decrease the eosinophil level. That is the interleukin 5 or the 5 receptor blocker. So if the FeNO level is high, that is the airway inflammation is high, as I mentioned before, we have to use interleukin 13 blocker, because interleukin 13 causes airway eosinophilia, hypersecretion, etc. Okay. Now we look into the different comorbid condition, and we can select which interleukin blocker to use as well. Okay. In real life practice, I use, if it is an IgE disease, I use omalizumab. If it is the other variants of asthma and they have nasopharyngitis, if they have atopic dermatitis, I usually use the Dupixent, the interleukin 4 receptor blocker that downregulates interleukin 4 and 13. Now, if they have blood eosinophilia level that is high, then I will block the interleukins that will reduce the eosinophil level, that is interleukin 5 and the 5 receptor blocker. Okay, so this is how we treat, and if they have reaction to one, we change it to the another one. Then when we talk about the thymic stromal lymphopoietin, so it's a driver of eosinophilic and neutrophilic inflammation, and it causes the airway changes as well. So if you target the TSLP, you are looking at the allergic, eosinophilic, neutrophilic, and the paucigranulocytic variant. So if I have an asthmatic patient that I gave Xolair, Dupixent, the interleukin 5 blocker, and none of them is working for these patients, then I might consider the TSLP, because it affects all the pathway, and maybe that patient has the paucigranulocytic variant, and maybe they'll respond better to that. So that will bring us to the navigator trial, that is the tezepelumab in the management of asthma, and it has been shown to reduce exacerbation and improve quality of life in symptomatic patients. So there is a good podcast in this website about the navigator trial. For all the trials that come out in New England Journal or the CHEST journals, they have podcasts that we can listen to where they explain most of the physiology, the pathophysiology and medications, and they have debates on these topics as well. So when we use the anti-TSLP agent, so patients with low eosinophil count and patients with low FeNO, they didn't reach statistical significance. So I'm not sure if we can use it in that group of patients, but since it affects different pathways, we think it's better than any other agents. So I haven't started to use this more commonly. I have only few patients on this medication. It's very difficult to get it approved as well. I'm not sure if I have time to go about pregnancy and biologics, because I was told it was a 45-minute talk. So when we talk about pregnancy, we don't have much trial to say that if it is safe to use these medications in pregnancy. So when I have a patient who is difficult to treat asthma, who is on Xolair or the omalizumab or the anti-IgE monoclonal antibody, then I usually try to continue that medication, because in pregnancy, it's important to control the asthma too, because we don't want them to go into asthma exacerbation, intubations, then the fetus will be affected more. So the only trial that looked in pregnancy is the EXPECT trial, and they did not see any congenital anomalies, prematurity, low birth weight in this group of patients. But the sample size was very small. So we do not know if it is safe. But when it comes to pregnancy, the only medication that can be safely used is the Xolair. If their symptoms are controlled well on Xolair, then I continue the same. But the other biological agents, we are not confident enough in continuing. There are many clinical trials going around with the other biological agents. So, the Xolair I continue, but the rest I do not continue. So I'll stop there. I do not know if it is relevant to the practice there, but it's an interesting topic to know about asthma.
Thank you very much. Thank you. As I expected, you had a wonderful presentation. Excellent. And we have got an insight into the new development in the bronchial asthma. That is what is actually gained out of it. I think it's a wonderful talk. Really appreciating on behalf of the Department of Medicine and as well as the Believers Church Medical College. We once thanking you for the participation, and we anticipate your participation in near future also with us. Thank you very much. So,
does anyone have any questions or anything for me?
About any effect on tuberculosis, latent TB?
Yeah, that question is the incidence of tuberculosis after post-treatment of this and biologicals.
Over here, we have not. I haven't seen it. Maybe the incidence of TB is very low here. So it's not something that we look for in asthmatic patients. But when we use monoclonal antibody in other diseases, like rheumatological conditions, they usually check for quantiferon gold before they start the immunological agents, biological agents. But in asthmatics, we don't check for quantiferon or TB, prior to starting this medication, because we assume that the incidence of TB is very low here. And I haven't seen any TB flaring or TB from the use of these agents. There was Xolair was thought to have increased incidence of cancer, but then the latest studies did not show that. We don't know the long-term effect of these agents, by suppressing the interleukins and eosinophils, where there is increased risk of cancer down the road after 30 years. We don't know, but I think it's less likely.
Yeah, another question is, what is the lower limit of the use, like in pediatric group?
So most of the treatment is up to about 6 years and older. Okay, so I have it here. So it's about 6 years, except these two medication is about 12. Dupixent was about 12, but they changed it to 6 recently. So about 6.
About 6.
About 6 years.
Approximate cost in use, that's what we wanted to know. Yeah.
So it can cost from $10,000 to $50,000. If it is not covered by insurance, it's tough to use these medications.
Next question is next question from is what about how you test environmental allergens? Various testing and serological testing for allergens. What is the ideal testing for the allergens?
So for me, before I consider these agents, environmental testing is very important because we want to decrease the trigger or the allergen exposure in asthmatics. So what I do is I do the blood test for the common allergens that we have. We have extended allergy panel like done in Mayo Clinic. So we sent it out to those centers to do extended panel as well. Very less likely, over here, we don't use the skin prick test that frequently now. It's all blood test. Then we check for the IgE level. And most of the homes here have mold, the Aspergillus mold. So we check for Aspergillus antigen and antibody as well. We have home inspectors. So I have a home inspector that I contact if their house is suspicious. So they'll go to their home, inspect the home, and let me know if there is any allergens or trigger, like dust mite is one, mold is one, and then different kinds of, other funguses are also there. So they will go into their homes. If there is a water leak, over here, in between the bricks, the water can accumulate and cause mold to grow. You cannot see the mold, but every time they go to the basement, they get the mold exposure and the exacerbation. So their home inspectors are there who go out and inspect their homes as well. So we do the blood test, we do the home inspection, and see if they have any pests or any allergy to the pets that they have.
What's the question? That's all.
What's that? I didn't.
Ramesh.
How long?
Yeah, how long to take? That's an duration of how long?
How long we give the biological agents? So I have few patients who have been on Xolair, and then their symptoms got better, and I slowly taper it off. In that group, 50% are still not symptomatic, but some of them with seasonal changes over here, they develop symptoms and go back on the medication. So I have patients who have been on Xolair for more than 5-6 years. The Dupixent was approved only in 2017. So I have them, some of them for 2 or 3 years. It's very difficult to wean them off these biological agents. So we try, but most of the time it has been unsuccessful. Most of the time it's indefinitive. We continue it for a very long time. Every year I give them a chance to come off the biological agents. If they do well, I keep them off the biologics for a few months. If not, then I restart it again. Sometimes we give one agent, and then after some time it stops working. Then we stop that and change it to another agent. So, for now, it has been given for a very long period of time. So some of them are on these injections for more than 2 years. But every year I give them a chance to come off the medication.
I think almost all questions were answered very well, and Dr. Manju has had a wonderful, I think recently is one of the wonderful talk, excellent, and thank you very much. Thank you once again.
Usually I do like a case, interactive cases at the end, but because of the time limit, I couldn't do it. Next time, like for the students, not for the attending, so, we can do like interactive cases, because I just wanted to know, in Zoom section is very hard to interact, to know how much they understood. So I usually ask questions at the end so that they can clarify the thought process and the treatment. So we'll do something like that next time.
Thank you. Next time. Next month.
Take care. Thank you.
Thank you.
Thanks. Good night here and good morning there.